So I was asked to talk about unicondylar versus HTO. This is quite a common question. Huh? Yeah, okay. So there's quite a common question on osteotomy. First, I want to excuse for speaking English to you. As a matter of fact, my Italian is crap, so you don't want to hear that. You can talk to me in Italian. Half of that, what you say, I understand, and the other rest, I just smile away. Okay. Good. So I was asked to talk about this topic, and as a matter of fact, it's a common topic because people constantly come and want to make up a battle in between unicondylar endoprosthetics and HTO, as if this would be the deciding part, and all the patients basically would be suitable either for this or that, and if you have a varus, it's either this or that. As a matter of fact, the answer is quite simple, and I will get you through there. And then you get some certain idea of what indication finding on osteotomy is all about. So basically there's clear criteria for at least 90% of the patients, and we don't want to really discuss and keep going, talking consequently over these 10% that might be around being suitable for both procedures. Let's talk about the 90% that you can easily detect in your outpatient center, because it makes sense to cover the whole bandwidth and the mass of people that want to have treatment, and not this tiny proportion that might be a case of doubt. Okay? So we just step into that, lezione magistrale, falsi miti sulle osteotomie e come decidere tra osteotomie verso in Italian versus in English verso protesi monocompartimentali. That was not bad, huh? Okay, just so I can say that in English, of course, but that doesn't make sense. So let's step into that. So partial knee reconstruction and grade of osteoarthritis. So of course there is good results in partial knee reconstruction. I mean, otherwise we would not do that, and it's out for decades. But as a matter of fact, osteotomy was there even hundreds of years before. So, but there is clear indication for partial knee reconstruction, and this is Kellgren-Lawrence grade 4. Bone on bone. That does mean this here, and this here, and this here. All that is suitable for unicompartimental replacement. If you're not in this stage of the disease, not bone on bone, then unicompartimental replacement doesn't play any role. So there's clear criteria that this is demanded. So in early stage osteoarthritis cases, like 2 or 3 Kellgren-Lawrence, the results are completely unpredictable. And this is proven in many, many studies. So as a matter of fact, this is one very, very big classifier for your decision making. Do I have Kellgren-Lawrence stage 4, end stage osteoarthritis? If you don't have that, you don't have to discuss anymore. So now these guys in Nuffield Orthopedic Center, which is just around the corner of Oxford, they made up their mind and thought, well, what kind of patients do we see in our outpatient clinics really? So what do these patients have that come in? And they made their statistics and found out that amongst these people having severe medial knee joint pain, just 25% of those patients, so 1 out of 4, is showing up with full thickness cartilage defect end-stage osteoarthritis. So that does mean that 3/4 of all your patients that come in automatically don't have, even if they have a varus malalignment, they just don't have an indication for uni. Doesn't make sense. So 75% are already pre-decided. Very simple criteria. So of course then we need to discuss about these other ones, but this is just like, remember, 25%. So looking at frontal plane deformities, we know that varus or valgus malalignments may cause osteoarthritis, as osteoarthritis is a disease of mechanics. And if you have hyperload at the lateral side in the valgus, or in the varus case at the medial side, this is basically odd that this leads to osteoarthritis over time that causes deterioration. And Agnes Kirchner from our group proved that basically by showing up in these bicardanic fixated human knees and this cadaver study in a mechanical testing device, that you can shift the loads from one compartment into the other by performing an osteotomy. So it's proven data actually, which is out, and it's out for ages. We look now at epidemiologist data, these are guys having no idea of surgery at all. They just look at tables and compare what patients throughout populations have. So this is epidemiologist's data, Felsen study, and he states basically that osteoarthritis is a disease of mechanics. And it is. And we know that 3-degree increased deformity in the frontal plane or 3 degrees of malalignment, they lift the risk of developing an osteoarthritis. So just 3 degrees are enough to develop an osteoarthritis once in time. If you have 4 degrees of deformity, you have 3 times the risk for an osteoarthritis in comparison to normal population. And the progression of this osteoarthritis, once you have an ongoing problem within the joint, such as meniscal tear or already cartilage defects, then the progression is 15 times faster than without a deformity. So that's also a proven concept. Now let's take a look at these patients again that are in our outpatient clinics having these limb deformities. So this is a study from Bellemans, which was interesting because Bellemans was just having the same question, what kind of people come into my outpatient clinics? And he just went to a cinema in Brussels and asked the cinema visitors to undertake a full leg x-ray, weight-bearing x-ray of the lower limb. And because no one takes full leg x-rays when you want to go to a cinema, he gave them 100 euros. So, and basically he just picked the first couple of hundreds and made up his statistics, and he found that 1/3 of the male population has a constitutional varus deformity which is higher than 3 degrees, and even in females you have 17% of constitutional varus deformities, which is surprising, I guess. So you, amongst the normal population, have quite a big proportion of people presenting with deformities, and this was just for the varus. There is also the valgus, of course, in lower proportions. So you can say that like 50% of all the people running around having deformities of the limb that set them in charge to develop an osteoarthritis once in a while. So how do these guys now look? I mean, this is a typical chap. This is a colleague of us. He presented in our outpatient clinics. And once you develop this, or you have this preset alignment, and you run all the time like that, then obviously this leads to medial deterioration, which then leads to even further varus alignment. And then you have both a constitutional deformity, which always has been there, plus medial wear, which leads to even further deterioration. And then you have an assumption of many things. You have a constitutional varus, 1. You have an intra-articular varus due to wear, 2, and most probably by time, because of the over-tensioning of the lateral bend and structures, you have a ligamentous component of the deformity, which is 3. And you as a surgeon, your role is now to differentiate between those 3, what always has been there and what is the major problem of the patient, of course. So, established indications for osteotomy. Now, obviously, it's Kellgren and Lawrence 0 till 3, because that is what is not in the group for the unicondylar replacements. We learned Kellgren and Lawrence 4 is quite often a good case for a uni. These ones not. So therefore, this is the constitutional deformity that makes up the difference. And this is in England, or in the Anglo-American literature, the so-called treatment gap. As they don't have any idea about osteotomy, they just take the patient and say, well, that's a treatment gap. I wait till they come to the stage where they have full thickness defect, and then they get a uni or total. In 90% of the patients, it's a total, because if you have a hammer, everything looks like a nail. So in this case, we try to do it better and restore the knee and keep it as long as we can. Keeping it as long as we can, of course, we as osteotomists, so as uni surgeons, we have to confess, are always confronted with the dilemma of survivorship. So all the registry in the world always makes up survivorship data and wants to tell you that survival of your treatment is basically a good classifier to tell whether the treatment is good or appropriate or not. So looking at HTO survival rates over these times, and this data comes from basically ancient osteotomy times, where the technique was not as improved as Michele just beautifully showed with all the dropped complication rates. So this table or these charts come from times where we had a bandwidth of treatments being completely heterogeneous. So, and even then, we found in this meta-analysis by Spahn that the survival was at 91% after 8 years, and after a decade still at 85% approximately. So that's altogether seen not bad at all if you consider that we restored the knee and did not burn any bridges. So the treatment even then was good. So we made our own study on 533 patients in 3 centers, and all this concept was like the medial open wedge high tibial osteotomy with a tomofix. And that was in Tübingen and Nijmegen in the Netherlands. So it's multicentric. And to examine our patients, we translated and validated this Oxford score, which already was there for knee osteoarthritis and replacement surgery for unis. And we validated this in German language to have something to compare to the Oxford group. And as a matter of fact, throughout all these centers that were in the study, basically we found that the post-operative results were overall, after 3.5 years, better than with an Oxford knee, and way better in comparison to a total knee replacement. So what really makes it up now? It's the constitutional varus deformity, as we said. So you just get good results if the indication for your patient is right. I mean, this is also basic knowledge, actually. I mean, if someone comes to you with a cuff and you treat him with an HTO, the result won't be good. So you need something, actually, which fits together. And in this case, it's the constitutional deformity. Now, what is this constitutional deformity? And there is a nice concept from the Lyon work group from Bonin. And he found out about this tibial bone varus angle. This tibial bone varus angle is defined by basically the angle of the proximal part of the tibia in relation to the mechanical axis of the tibia. And I don't want to show it up here because it's out in literature, you can really look it up. But anyhow, it gives you a good idea on how the metaphysis of the tibia looks alike. And if the metaphysis of the tibia preserves a varus deformity, then the results are most probably good. If the malalignment in the proximal tibia is 5 degrees or more, then 85% of your patients after 10 years will have good or excellent results with an HTO. If there is no deformity, the results will be crap, and you should not shoot for an osteotomy. But that's plain, huh? So if we look now at comparative studies for osteotomy versus partial knee reconstruction, you can find hints in each and every direction. So there's pros and cons for everything. But if you look at all these typical prejudices that are there, for example, age, activity, and survivorship, then we have to confess we looked at our own data. Is there really a deciding factor in terms of age for osteotomy? Because we are all taught in Europe more than in Asia, for example, that osteotomy is something for the young patient. Well, let's take a look at that. We have checked our own 533 patients, and we found that throughout the whole bandwidth of people, there is no difference at all. We were surprised ourselves, but in fact there is not, and even and especially the old ones, they really have quite strong benefits. Looking to other countries, that was always there, actually. So no one in Asia would discuss if it does make sense to treat elderly people. This is in Japan. There's a study from Takeuchi, and Takeuchi was now publishing in his study just the patients above 70. Now, 5 years later, he brings out the next study, just the patients above 75. So who of you would do an osteotomy on a patient being 75 and older? Of course, that looks awkward. I mean, I don't know if this is the typical Japanese way of testing patients later on, but seems quite dangerous to me at that age group. But anyhow, it's fun.
They don't feel the proximal.
Yeah, in Germany, even the patients being 30 can run like that. You know, that's the problem. So, anyhow, so yeah, we can skip that. So, looking at activity levels, that's the next thing. I mean, we were talking now about age. Forget about age. Age is nothing that you should ever take into consideration. Yeah. Age is absolutely, that's no classifier for deciding on an osteotomy. Key point, age, forget about it. Activity levels. Well, of course we say, well, if your patient is rather active, you should shoot for an HTO maybe, because joint reconstruction with unis or totals is a little bit critical in terms of activity. Well, looking at it from the other way around, if you look at the Tegner score and patients undergoing unicondylar replacement, then we know that 1/3 of these patients come back at activity levels which are really tremendous, up to soccer. You know, I mean, this is just a small proportion. But if you want to treat someone who wants to be active again and he has a full thickness medial defect, then a uni ain't a bad shot at all. At least you can tell your patients at a likelihood of 35%, you have a good chance to develop a high activity level again. So deciding on unicondylar versus HTO on activity levels is also not a good idea. So what remains basically is the metaphyseal deformity of the patient. So revisions for uni, but also or reasons for revisions for uni, but also for high tibial osteotomies. Well, we looked up the data from the Oxford group, and they of course always complain about being blamed that the surgery is moreover revised in comparison to a total knee reconstruction. So looking now, the reasons for that is unexplained pain, contralateral osteoarthritis, aseptic loosening, infection, fracture, or implant failure. Well, we know all the list basically from the HTO, huh? So we are accused for that as well, and what remains at the end, at highest proportion, is unexplained pain. The problem with unexplained pain is it remains unexplained. So no one knows why these patients are revised actually. The biggest reason why these patients, uni as HTO patients, are revised is because we can. The reason for revision is the bias in ourselves. I mean, now imagine you have a patient, like this chap here, having a total knee, coming to my clinics, telling me he's tremendous pain at his right knee. Michaela, how do you feel?
Bad.
Bad. So is it daily or is it aching always?
Night.
Okay. How long can you walk without pain?
100 meters.
Not fewer. Okay. So now this is your patient and he has a total knee. What do? Oh yeah, no, you send him home. He has a total knee. You send him home. Now the same patient comes to you undergoing HTO, stating the same. What will you do? Yeah, right, you put in a total. Of course you do, because you have options to give. So that's the dilemma that we have. We are biased. So there is good data in the UK, and the best implant in the UK registry, which has the biggest survivorship, and is the Sheehan knee. All our problems are gone. We don't have to find any further solutions for uni or osteotomy. Forget about it, we don't even have to sit here. The best knee with no revision at all, ever, in the UK registry is the Sheehan knee. The Sheehan knee is out since 1972 and it's not on the market anymore for, I guess, 10 years. So this is the best knee which is in the UK registry. This knee is absolutely unrevisable. No one touches it. Huh? So that's the reason why it shows no revision. Yeah? So you can just crop the bias yourself. Huh? That does not make sense to look at it from that perspective. So of course you need to osteotomize, and osteotomy always, if there is a deformity, we learned that now. The deformity is key. But if you want to osteotomize, then you need to look where your deformity is. And this is the plenary session. We need to have some planning. If you don't analyze your malalignment, you cannot correct it. Well, you can, of course, and say, well, this is a varus, so it's an HTO, and this is a valgus, so it's a distal femoral osteotomy. This is how I grew up. Basically, that's completely insane, of course, because you never checked where the malalignment really is. And this is what we want to learn here. Otherwise, you cannot decide on your procedure, because a varus can be in, as we learned, the tibia, but it also could be in the femur, or it could be in both. And same counts for the valgus, which could be in the femur, it could be also in the tibia, or it could be in both. So once we started in Hanover with a systematic analysis of the malalignment, we came up with the fact that 20% of the overall malalignments are originally in the femur or in both, but at least then in the femur. 20%. And we treated just 1% of our osteotomies at the femoral side. So 99% of our osteotomies were tibial side. And that does mean that 19% of our patients were treated at the wrong bone. So we have had to realize, with a little bit of self-skepticism and criticism, that we were completely wrong, because we did no analysis of the malalignments. So how does this now look? You will come up with this, huh? I can skip that. So we skip that, you will see that later. I just want to stress that here. This is basically the joint line orientation. We call that Mikulicz or weight-bearing line. And the weight-bearing line is interesting because we were told that this is the one thing that you need to look at in terms of osteotomy. So when you have a weight-bearing line like varus, then it passes medially, valgus laterally, it's quite clear. And we need to put it to the Fujisawa point, to whatever that is. So it's a little more tricky than that, I have to confess. Of course, the weight-bearing line gives you an idea, an overall idea if it's varus or valgus, but it doesn't give you an idea where the varus or valgus is, and it doesn't give you an idea how the joint line orientation sits. And this is as important as the Mikulicz line. So we have the mechanical lateral distal femur ankle and the medial proximal tibia ankle. You need to check that. But in stents, in normal stents, it's completely uninteresting what happens because you spread your body weight in 50% on each leg. So it really counts when you're under dynamic conditions. And this is where kinematic alignment comes into play. Huh? Under dynamic conditions, you running, jumping, hiking, whatever, you medialize your foot to gain balance with the center of your pelvis above your foot. Okay? So this is when you have like 4 or 5 times your body weight on your knee. And what do you do then? You medialize your foot. And whilst you medialize your foot, this oblique joint line, which is inclinated by 3 degrees, suddenly turns out to be horizontal. So in fact, an oblique joint line ain't oblique at all. I mean, nature or evolution is not an idiot. But the engineers who designed the total knees, basically they knew better. And they put it all to 90-90 rectangular cuts. Of course, that's insane. Well, because if you cut at 90-90 in this position and then you medialize your foot, then you have an oblique joint line and you created exactly what you wanted to avoid. So that's crap, of course. Huh? The concept is like that. And what we want to restore is this, because that's best. Huh? If the joint line orientation after an osteotomy is too far away from this position, then you create shear forces. It doesn't matter where your Mikulicz line sits. If your joint line orientation is not perfect, it will deteriorate. And there are guys who showed us, this is this Takeuchi study, this Fujisawa study, basically the original study, where he stated, who of you knows where the Fujisawa point is? At? 62. 60. Everyone says that. I cannot blame you. Yeah?
It's an area, it's not a point.
Okay, where is it? From?
It should be between the 30 and 40% of the...
Yeah, right. That's it. It's between 30 and 40% of the contralateral compartment then. And this is basically between 60, if you bring this here to the other side, then it's 65 till 70% of the tibial plateau width. This is what Fujisawa wanted. And being confronted with it from Professor Lobenhofer, he said, I never want to be cited for that. It was never my idea to give a recommendation. It was just Asian knees. In my philosophy, it has to be way further lateral. So it's basically what the whole world sets the point on, but no one knows where it is. In fact, it was Frank Noyes, along with Dugdale, who came up with this study, because he thought 65 is a little bit too far lateral, and then they published this one, and there you see the authors empirically select a 62 till 66 weight-bearing line tibial intersection that approximates 3 till 5 degrees of valgus mechanical axis. So basically, they were just guessing. Empirically selecting is guessing. So Bob Taichi from Detroit, a great osteotomist, asked Frank Noyes, Frank, how do you come to this, or how did you come to this 62% intersection? And he said, because it had to be some figure. So actually we have to say, we don't know. Today we rather go to 55 till 60%. So we are even under this recommendation from Noyes and Dugdale from back then. But there were guys back in the Mayo Clinic even smarter, like Edmund, who is an engineer, Edmund Chow. And Edmund Chow said, well, if there is a testing concept for that, where can I find that? So he looked into the mechanics of the car engineers in Japan. And they had a rigid body spring model for creating mechanical models, actually. And so he just transferred this rigid bone spring model to the human knee, added some quad forces, muscle forces, and so on, and fed all the results into a software, the Oasis system, that was back in the in the 90s, actually. So, and he asked his software, well, this is my malalignment that I have. If I now, with a Mikulicz line passing here, if I perform a high tibial osteotomy, back then it was the lateral closing wedge, how does the joint line look? And the software then said, no, stop, that's not a good idea. You can have the same Mikulicz line correction at the same point by performing a double level osteotomy. So in fact, it was not Edmund Chow who calculated these osteotomy types. He just fed it into the software, and the software came out with a solution. But Edmund Chow was no surgeon. Back those days, there was a guy called Babis, who is now working in the Cappadocian in Athens, head of department, and he was a fellow back then in the Mayo Clinic. And he said, well, if the software is smarter than we, then I do the surgery, and the software does the calculation. So, and after that, he published on those double-level osteotomies, and he found out, it was published in 2002, double-level osteotomy, a method to retain joint line obliquity. So, and he published on that with an acceptable joint line obliquity of 4 degrees. And this comes back to the 4 degrees that we were talking about when I started the lecture, because 4 is somewhat what you can expect to be a problem from epidemiological side in terms of developing an osteoarthritis. So the survivalship of these double-level osteotomies at 7 years is 96%. It's the best ever published figures in literature. So it's tremendous. If you just believe the software and the joint line orientation plus the Mikulicz line, then you are at the right spot. If you don't do so and compare all the others, the outliers, in comparison to the good ones, so they checked their own patients 8 years later, and then they found out that the outliers that were amongst these 4 degrees of acceptable joint line obliquity, they deteriorated over time. So if you don't get your joint line orientation right, your patients will deteriorate in osteotomy over time, regardless if they had a metaphyseal deformity that you treated or not. You need to treat it at the right spot. Okay, we will go into planning and teach you. So we have learned not all the deformities can be addressed at the tibia. The joint line is also important. If you treat this chap with a big, massive varus deformity and put it to somewhere at Fujisawa, whatever that is, and open it up in a medial open wedge, then you end up with a post-operative medial proximal tibia ankle of 100 degrees. This is 10 degrees above the normal range and worse than the patient came. So you should not do that. You go back to your drawing board, and this is why your question was, I guess I got it, I mean it was Italian, but you asked about filling the gap and the height, actually. I can tell you, since I make double-level osteotomies, I never come to openings of 15 millimeters anymore. if there is a 15 millimeter opening, that does mean you've had a malalignment of 15 degrees prior to the surgery. If you have 15 degrees of malalignment, either the MPTA was 78, or you also have a deformity at the femur. And what I then do is, I treat both bones, because both bones are malaligned. Okay? So don't fill the gap up to that, you don't have to. So there was such a chap having this. It was a candidate for life surgery. So this was the femoral malalignment, LDFA 92, and the MPTA was 85. He had an HTO at the other side, we did already, and this one was now planned for the life surgery. What would you do in such a patient? What would be your recommendation? Where's the major malalignment? It's in the femur, huh? Obviously. Does he have a varus? So basically, we made this planning and we found if we just make an HTO, because he had it on the other side and he has a varus, we have 100 MPTA after the surgery. So we decided to go back to the drawing board and make a planning again. And that was our planning, and we distributed the opening here to a closure of 8 millimeters at the femur and opening of 6 at the tibia. And this is what we made then in the surgery. And this is the surgery. And that might be good just to tell you now for the sawbone session what you have to do. So this is a minimally invasive surgery, and you will see that tomorrow in the cadaverics. So you just make a little incision above the region of interest, shoot K-wires. I don't do 4 anymore, I just take 2 K-wires, 1 at each side, and this is very fluoroscopically guided. Okay? Then you just do the osteotomy, and after that osteotomy, you make your ascending cut. So this is also a biplanar osteotomy. Just the posterior 3/4 are cut in terms of the wedge that you take out. And the ascending cut is then a complete cut. And now the problem is to close, this is the wedge that I take out, and the problem now is to close the femur, because it might not be a 100% precision. So what I do now is I just go in repetitive movements in and out with my saw under constant closure of the gap. And when you go in and out, then you swipe away all the remnants that might be in between. Because when you close and you can't close anymore because there is an obstacle, but you go on, then you crack because you distract the hinge. You shall not do that. Just take your saw to clean the gap. So then you apply the plate, just as we see here. Make a lateral X-ray to prove that it's in the right position, and then you fix it. Yeah, right. You take you see, I don't take any retractors in the back. I just take my finger and put it to the back. Place the saw blade on the finger. I rather cut my finger than the popliteal artery of the patient. Huh? It's not a very sympathetic image to have, so you need to be very careful. But anyhow, your finger is better to cut than the popliteal artery. Huh? What you might develop is some blisters because of the movement of the saw blade. So this is why I use this precision saw. And this is now the tibial side. Sorry, you see it stretched a little, so it was on 60 to 9 ratio. And here you see the K-wires inside, and there is no retractor in the back. Even for the tibia, I don't take that, but it's not the general recommendation, okay? Because you can feel the dorsal cortex with the tip of your saw blade. Okay? I use this tip of the saw blade and rather make tapped sawing. Okay? You try to tap the cortex and ride on it. Okay? So then you gradually open your osteotomy, as we see here. You measure, of course, how long the osteotomy streak is, the intraosseous part, and then you reduce it by 1 centimeter, approximately, so that you know how deep your chisels go in. And then you alternating, like serratus anterior, you alternating bring your chisels in not to distract the hinge. And once you have opened it, you put an osteotomy spreader inside, prove with a rod that you are at the desired opening, and then you fix it with a plate. Okay? So this is the chap after the surgery, 8 months post-operatively, and the right side was treated, as we said, and we retrospectively checked if we did some nonsense at the left side, but there was no femoral deformity. It was luckily just an HTO. So, important factors.
Sorry, speak about screws.
Okay, so screws that we put in. We start at the femur. You see there is like 2 monocortical screws here. I don't take bicortical screws at that height.
Why?
Because I have 1, 2, 3, 4, 5, 6 cortices above the osteotomy. 5 should be enough. So this is even an over-treatment. This already could be monocortical. But the lever arm at the femur is longer because the osteotomy here is here. This is your lever arm. So the forces that are applied are higher than at the tibial side. So the femur is brittle. And then you don't have something like the proximal tib fib. This does not exist at the femur. So the femur is a very, very critical bone to treat. Okay? The likelihood of fracture for the hinge is way higher than at the tibial side. Okay? So the 2 screws are just monocortical, these ones I take bicortical, and these ones are just as long as you can put them. And this is why you should make a lateral X-ray when you have it temporarily fixed with K-wires, 1 proximal and 1 distal, just to see that you're perfectly aligned with the femur. And for the tibial side, all the 3 inferior screws are monocortical, that's enough. And it gives you another option. Once you just make not a biplanar or double level osteotomy, but you make just a HTO, and after the surgery you see that the patient wakes up like that, and you've maybe overdone it a little bit, then you can still bring him or her back to the OR the next day, take out the screws, close it again a little bit, and then you shoot for the second cortex. So you have a second line of defense. Okay, don't destroy this second line of defense at the first shot, you don't have to. This is bicortical because it is in the neighborhood of the osteotomy. This is mandatorily bicortical. Never forget to place screw D. You see these images again and again, and then colleagues come and say, well, the plate is cracked, it has a fracture here. Yeah, it fractures here because you have a combi hole. This is why the metal is thin. But the plate is a calculated system, and if you don't put the screw inside here, even if it's just a spacer, you lose the whole concept of stability. So it's mandatory to put a screw inside of hole D. Okay? You can forget about all the others, apart these 2. Okay? So, and then you put these as long as you can get them again. Okay, important factors, I've overdone my time anyhow. Constitutional deformity is key. Very important. And that's the only key. Forget about age, forget about activity, forget about smokers, forget about obesity. It never has turned out to be a statistical problem. It might be an individual problem, but we are talking about evidence-based medicine, aren't we? So this is not a problem in terms of this observance. So stability of the knee, of course, is a factor, because with an HTO you could also treat ligament problems, but we don't step into that right now. And the stage of osteoarthritis is very important, because a full thickness defect might be somewhat rather a case for uni. A partial thickness defect is a case for an osteotomy, and there's just a small overhang of 10% that might be favorable for both, especially the young patients who develop a full thickness defect with a presence of metaphyseal deformity before the wear of the knee. Okay? This is just a small proportion. I really want to not talk about that because this is less than 10%. Let's talk about the 90% that are really important for you. Thanks a lot.
Avete domande per Kristian?
Hi, I'm Zaolino from Gaetano Pini Milan, and I just have a question. When you do perform a double level osteotomy, you don't have the trouble in mind to have one side that doesn't heal correctly.
Yeah, right.
Just like
Good question. The question is okay. I can speak up. It's okay. We just spread the mics. The question is double level osteotomy does mean double trouble. Yeah. So as a matter of fact, the opposite is true. Of course we thought like that when we were starting with double level osteotomies. But it is way worse, it's way worse to say, oh no, I make my compromise on this one. I want to avoid a double level osteotomy, and therefore I rather make a HTO of 20 millimeters. Okay, staged performance. Yeah, well, you could perform any surgery staged. To be honest, we just can't do this because we are quite quick at that, and the reimbursement system in Germany allows us to do it at least at a non-profit surgery. If in a country like Italy you will get a reimbursement, for example, for just one plate for the whole procedure, and you end up at, I don't know, 5,000 euros for an HTO or a double level osteotomy, is it a difference? So it's no difference. Okay, in Italy I most probably would do it staged. Yeah, I mean, we have to be honest. I mean, you could do this in a one go, but if you do this after like 100 procedures, your hospital manager approaches you and tells you, it's nice that you worked here. For how long have we met here? Huh? So, and then you don't have the option to treat patients in that hospital anymore. That doesn't make sense. Obviously, of course, from the medical standpoint, I tell you, double level does not mean double trouble. You can easily give it a go in one shot. But if your system doesn't allow you to, then we are talking about something else. Well, we cannot help that. It's not wrong to do it staged. The only thing which might be a problem, I always take the femoral wedge and take it and transfer it as autograft into the tibial side. So you have to keep it at home in your refrigerator till then. Okay.
Hi, I'm Gianluca Canton from Trieste. When you perform a double level osteotomy, you always start from the femur.
Yeah.
Is it always the first step?
Yeah. Because the femur, the algorithm is like that. The femur, when I look at osteotomies, you can correct each and every malalignment around the knee with the femur always closed. I hate open wedge femoral osteotomies. You can do them for limb lengthening, etc. But once again, we are talking about colibris, you know, it's just a small proportion of people. I always make them closed. If you close them, then the healing at the femoral side is accelerated. Of course, a compressed closed wedge osteotomy heals within weeks. Yeah? If it does not, something is wrong. So I see them back after 4 weeks. Femur in my hands always closed because mechanically, as we said, the femur is brittle. The tibia always from medial. Because I hate to go to the lateral side. There is the peroneal nerve, there's the tibialis anterior, there's a higher proportion of compartment syndromes that you might create. So the reason, or the algorithm is simple: femur always closed, tibia always medial. And that does mean if you perform varus correction double level osteotomy, then you have one dedicated surgery which is basically decided prior. That's the femur. You need to close that. You cannot play around unless you leave it open. Huh? So you take that out. And then the tibia is for fine-tuning. You can still play with that, so it makes sense to do the tibia as a second shot. And apart from that, you still then, or you already have your gap, or your gap filler, your wedge from the femoral side.
Luca from Bologna. When you perform double osteotomy, does your approach to post-operative rehabilitation change, or you permit acceleration?
Yeah, thanks a lot. So the question was on regime of post-operative care. In a double-level osteotomy, the post-operative care is decided by the femur. So as we said, the femur is a complex case. The only thing I do different, I see a femur for the radiographs after 4 weeks, a tibia usually after 6 weeks. But for the tibia, there is a study from Herr and at least with the Tomofix or other angle-stable plate fixators, you can really dare, if the patient can cope with it, to let them weight bear fully at day 1. So you just let them walk, even if there is nothing in the gap. You can let them walk. I wouldn't do that with the femur. So the femur, isolated femoral osteotomies or double level osteotomies in my hands have like 3 weeks of partial weight bearing. Then I tell them they can accelerate, so that after 4 weeks, when they come for the X-rays, they are at maybe 50% body weight. And either that works, and we can go on, or it doesn't work because something is going wrong. And then you either see some cloudy formations at the hinge or whatever. Then you have to react on that. Some you just set on further restriction of weight bearing, some you send to shockwave therapies. So it's different answers that you give according to the findings.
Andrea from Verona. A question, like you say that the stage of osteoarthritis is really important, no, for deciding, and so if you have a Kilgren-Lawrence 4 stage. So for deciding the stage of osteoarthritis, is enough an X-ray? You do like arthroscopy before, or?
Yeah, so we completely abandoned basically to do arthroscopies before HDOs. So we found that in less than 1% we changed our indication. But in 100% we kind of touched the knee and brought something into it that we may want to avoid. So it's dragging an extra-articular surgery into the joint. Even though it's just arthroscopy, it doesn't make things better. Statistically seen, if you're decided early on, then you don't have to do an arthroscopy in advance of an osteotomy. Apart from two things, loose joint bodies and meniscal locking. If you have locking flaps or buckle-handed tears, well, I mean, that alone is an indication for an arthroscopy. So, but just for degeneration, mild degeneration, it doesn't make sense to do arthroscopies. I mean, we know from the Swedish registries that it, and I told you my opinion about registries for some reasons, but anyhow, we know from the Scandinavian registries that it doesn't make sense to scope a degenerated knee. So we don't do it in HDOs. And in terms of preoperative findings and imaging, I strongly depend on my X-rays. Of course, I mean, if you make a normal weight-bearing X-ray, it might be a little doubtful, but if you make a Rosenberg view or stress X-rays, that's always explaining. So I advocate you to make a list of X-rays. 1, whole limb, full standing leg X-ray. That's the first one. Then you need, of course, the knee in AP and lateral. And then you need the patellar skyline, and then you need a Rosenberg or stress X-rays, if you want. And if you want to be very, very, very precise, then you also have stress X-rays from the contralateral side. But that's, you know, that's paramount.
My name is Aldo Fappani, I come from Russia. Do you think that osteoarthritis of femoral patellar joint is a criteria to avoid HTO?
Yeah. Well, clearly not. Clearly not. We have to confess. Well, there is different answers that we could give. It's a commonly asked question for guys who do unicondylar replacements, because there it might be even more of importance when you say, well, you want either you make a total and do all the best for your patellofemoral joint, or you just make a partial reconstruction. The problem is, total knee reconstruction was never meant to treat patellofemoral osteoarthritis. Patellofemoral osteoarthritis is anyhow random in the whole population. So if you ask the first 100 people passing by this room if they have knee pain, and you just pick the 100 that reply, no, I don't have any pain at all, and then you make MRI scans of those patients, then in 50% of those you find changes of the patellofemoral joint in terms of degeneration and osteoarthritis. So would that...
Symptomatic.
Yeah, so if you have symptomatic osteoarthritis, then you can still
you could still hypothesize that if you make an HTO and you make it in a biplanar technique, you change the height of the patella. So maybe the encountering parts, they don't touch each other anymore. And the next thing that you could say is, well, if it's rather a lateral osteoarthritis, there might be no changes at all. But if it's a medial osteoarthritis that you have and you open it up like that, in terms of a varus correction here, then you have rather a shift to the lateral side, which might be advantageous. So the only thing that might be critical, but you cannot say it's a complete contraindication, is a full thickness lateral facet osteoarthritis of the patella. Well,
What would you do?
well, I would still do the osteotomy and tell the patient that he has the chance of an ongoing progression of the PFJ.
What about the
Well, you could do plenty of things, but it's all, let's say, in that combination, we are once again entering in a phase where you talk about a small proportion of patients.
Special case.
Yeah, this is the special case. We can, of course, debate on that, but the question is, does it really make sense to talk about this patient who is 1.55 m, has BMI of 34, and you know, the closer you draw the line, the more specific it all becomes. I would just inform my patients, because you cannot, in these patients, as it's so neat and tiny proportion and subgroup and cohort of patients, you cannot give statistical answers. So therefore, I would approach these patients individually and tell them, I cannot tell you how this might react. It might go to this and that direction. In this case, like, it becomes more and more appropriate. Consenting the patient is very important and will be moreover in the next couple of years and decades. So you need to inform your patients, and they need to sign that you informed them.
Hi, my name is Gianmarco from Brescia. I would like to ask you, what's your planning technique of choice in your practice?
Well, I started actually in the traditional way. So when I started, I just had printed X-rays. So I was standing there. The first thing I did for planning was making the coffee. Okay? So because it was at the end of the day, it was like 7 or 8 in the evening, and I just was tired because of all the ward stuff that I have done, but I still knew that there are plenty of surgeries for the next day, so I had to plan those. So I prepared the coffee. I sat down and I collected all my X-ray prints, and then I had some paper and ruler and pencils and everything, so I drew it. Well, this is how I was started. It's the typical Miniati technique that we will learn. So, as a matter of fact, when we had digital X-rays, then it was way easier to do all the lines. But anyhow, it was still Miniati plain, like you do it on paper. So, and today, as I make many double-level osteotomies, it's really a help to use software that simulates the planning. It's really very helpful. So I've gone through numerous of those softwares. Basically, the trigonometry behind it remains the same. It's just the workflow that might be different and so on.
Sorry, do you know a company so it's not so expensive for them? Because
Well,
the problem is to buy for 2,000 euro per year.
Well, so the thing is, one of the cheapest solutions I found for myself, because now we had a contract with the AO JPEG group, and we constantly got software from different providers, and so I know the pricing from all of those actually. The cheapest solution I found was actually from Trauma Cut Brain Lab. So I recently renewed it, and I had to because our expired.
Did you buy one?
Yeah, I bought one. I had to buy a license for that. So even we don't get it like that. So I have now a 2-year license, and it cost me 1,000 euros.
For a year or
2-year license for 1,000 euros. So it's 500 euros a year.
No, it's excellent because I try to do the same.
Yeah.
The price.
Per month.
I just have to. But that was it was not a. I mean, there are different licenses, and there are licenses for the whole hospital. There are individual licenses.
I asked for individual.
Yeah, the individual license.
Not so cheap.
Well, you should. I write an email to Ian Wilson, who sits in England, basically. He's responsible for me. So it's not a German thing, actually.
So we should go directly
to Ian Wilson maybe. But 2,000 euros for 2 years, 1,000 euros for 2 years. I found that quite affordable. It's a cloud-based thing. So you have all your data available. You can talk on can plan on any device. It's 500 a year. You can also plan your prosthetics. I do all my hips and knees with this one. You have free template downloads. So altogether, I would say I plan every year 600 surgeries with this device. For 2 years, that's 1,200 surgeries for 1,000 euros. Is less than €1 for each planning. I guess that's affordable.
You can use, if you want, another one is cheaper, but you have to have an iPad, and the name is Bone Ninja.
Bone Ninja is not on the. I've checked that 2 days ago. Bone Ninja is not on the app download store anymore. It's not existing anymore. It's gone. It's gone. I checked it 2 days ago. Maybe if you check your iPhone, you have a red button on it, and that tells you shall upload it or update it. Yeah, right. It is. But anyhow, we checked. It was not there anymore. But anyhow. This is not a tool that you can use for, we talked about the consenting. The good thing about trauma care is you can even put it in your local PACS.
Yeah.
So you have a complete PACS connection, and do you have, in your PACS, you have a license for the viewer, I guess, for the PACS viewer. Usually the PACS company that approaches you asks you, how many viewing licenses do you want? And you have to pay for those. Where you can use the trauma care as a complete PACS license.
I have a question for you about the cases.
Yeah.
Because
Are we running out of time?
no. Okay, it's the last question. The last question, and then we go to take a coffee. And
Do I have to plan?
no.
Because
We go to take yes, and you can take your coffee because then he will explain us how to plan. And you will have 2 cases and some questions, okay? And you will have just 30 minutes for everything, 30 minutes, okay? But the last question is, we are speaking about many times. You have a 40 years old with varus pre-arthritis, okay?
Okay.
But it is not a constitutional virus. Is after a meningectomy. Okay, so you have
25 years old.
Yeah.
25 years old.
No, 40. Okay, and so
you need to decide.
okay. In this case, it's really difficult to consider a knee posterior. What do you do? Can you speak about palliative osteotomy?
Yeah, that is basically the question. Is it allowed to do a palliative osteotomy on someone without any metaphyseal deformity at all? Because I just explained, you look for the metaphyseal deformities, these are the guys for the osteotomy, and now he comes around with one of these colibris having no metaphyseal deformity at all, wanting an osteotomy. Well, the only thing that you can say in this subgroup of patients, once again, is statistically seen, look at the Beaumont figures that I presented to you, he has a likelihood of having a good result after this osteotomy of just 30%. That is what you can answer your patient. You can say, well, the chances of having a good result after this osteotomy are little, but you don't have any alternative. Yeah, of course I tell them. Yeah, of course. Well, I don't. You could approach a 40-year-old guy and say, well, you're in the treatment gap. That would be the Anglo-American way. You're in the treatment gap. You have some medial osteoarthritis. You have a partially torn meniscus. It will develop and progress by time. So in 15 years from now, you may undergo unicondylar replacement. Until then, take care that your ACL remains stable, because otherwise it will be a total, or you have lots of painkillers till then. So beware of your kidneys. This is the alternative. So my alternative would be, I tell the patient, well, we have a slight chance, it's not too good, but it's also nothing at all. We can do an osteotomy, and we can undo the osteotomy whenever you want. So it's, I mean, at least a chance for some further 10 years. Yeah, I do an osteotomy. Yeah, no, it's no problem. What do you do? You just ask, what do you do then? Well, most probably I do an osteotomy. The problem is, you cannot do like 8 millimeters or so. It's just an unloading osteotomy. It's just an unloading osteotomy, 5 millimeters, whatever. Yeah, yeah.
Okay, may I ask the last question? When you are performing an open wedge medial tibial osteotomy, when do you use a descending osteotomy?
Yeah, almost never. Almost never.
When do you decide?
Yeah, of course we have lateral X-rays, as I said, and if the patella is really almost nailed onto the tibia, or you have a Carton index which is I don't know, below 0.05, 0.6, whatever, really already then you go for a descending osteotomy at the tibial side, of course. And
how long is the?
Yeah, well, it should be like 4 or 5 centimeters, the length of the descending cut, and then what is very important from my perspective. If you make ascending cuts, it's auto-aligning. The patellar tendon constantly pulls in this direction, upwards, okay? So if you have it the other way around, the patellar tendon still pulls in this direction, but there is no stability encountering the osteotomy from below. So you should put a screw, a small fragment screw. Well, I'll just take one. The proportion, once again, is less than 1%. I guess less than 1% of all our osteotomies. I do this twice a year.
Okay.
Twice a year. You should never do that. Just send the patient to someone who does it frequently.
Yeah, but the question is, why in your hands you do only once, twice a year? Because you don't like it? Because
no, you don't see them. I could do that, of course, but you don't see these patients.
Okay.
It's just a proportional question. So this is why I would say, of course, you could debate. I'm biased by myself because I hate the surgery, so I don't do it. No, of course, it would be a logical question that comes up. So, but as a matter of fact, I don't see so many of these patients where you say they have a massive Baha, they have medial osteoarthritis plus metaphyseal deformity. It might be the trias of things, they don't come together, I don't know. So it's just 2 patients every year.
Okay.
But do you know descending osteotomy? Do you know? How many? Descending osteotomies, no? We are speaking, but there is descending osteotomies, okay? But we don't use more descending osteotomies, because if I see a 12 degree of varus, I think about femur.
Yeah, right.
Think about femur. After 10, think about the other side.
Then,
also with like
so you restrict yourself because you say if you have a slight idea of a Baha, then if you open like 14, 15, 16 millimeters, this is what we did back then. When we had an aperture of 15 millimeters, we recommended to do a descending osteotomy. Of course, you're right. As I said earlier today, I don't find 50 millimeters of opening anymore. So what I then do basically is I do them on 2 levels. Apart from that, if you have an opening of 10 millimeters, which is already quite some, 10 millimeter opening at the tibial side, then you have to see that, of course, at the aperture it's 10, at the hinge it's 0. Okay, in the middle you have like 5. But the Mikulicz line doesn't run in the middle. It's lateral, so you end up at 4 maybe. So there's 4 millimeters of changes, and then when you look from the side, you see that if you make an osteotomy, the back is wider open than the front. And the patella is where? Way in the front. So you end up not at 4 millimeters of change, but maybe 2.5. So a 10 millimeter opening, if you do it appropriately, results in 2.5 millimeters of patella height change. To be honest, even if there is a Baha at 0.7, I don't shoot for descending just for that purpose. It's just, you can, as a rule of thumb, if you make an open wedge osteotomy, the height, the wedge base height, a quarter of that results in the change of the patella height. A quarter of the wedge base height. It's not too much.
Ok, allora sono le 11:10, 11:25 ritorno e facciamo la pianificazione e poi andiamo avanti. Okay?